And with regard to the third one, that's about strabismus. So just to show you, for the benefit of those who have not had a chance to anesthetize the child for strabismus. So these are the various varieties of strabismus. And so you can see this is the normal vision child with a pupil in the center of both eyes. And this is binocular squint where both the eyes are rotated medially. This is divergent strabismus, binocular. Both eyes are rotated outside. Monocular. This is the normal eye. This is the eye where it has come to medial side. And again divergent. This is the normal eye. This is the deviated eye. So it can come towards the medial canthus or go towards the lateral. So divergent or convergent squint will be there. And this is the important pre-anesthetic evaluation. You must see whether it is an isolated strabismus or secondary to any muscular disorder, and whether it is associated with muscular disorder, there can be a chance of malignant hyperthermia. So you must always ask the history of malignant hyperthermia. The indications for surgery for a squint is mostly this must be functional. You must give a uniocular vision, not a binocular vision, and so it will be should have the single vision with both the eyes, and correct the cosmetic. It may look ugly, so you have to correct that cosmetic appearance also. And some children will change their head posture to adapt to get a uniocular vision. So their head will be constantly in a flexed or a extended position, and so that also has to be corrected. Some of the coexisting serious anomalies which can happen in patients with strabismus are they can have congenital heart disease or cardiomyopathy. So make sure that you examine the child for all these things. And coexisting CNS anomalies can be cerebral palsy, leiomyosine, hydrocephalus, craniofacial syndromes, or neurofibromatosis. And so this is the case of you can see classical sunset sign and hydrocephalus with a large head. This is an Apert syndrome child, and this is a cerebral palsy child. So sometimes they can ask you about the applied anatomy of the orbit also. So to change the monotony of asking the same question, they can ask you about the orbit and their anatomy. So what bones form, all that names that you have to know, and the normal depth of orbit is in an adult is about 55 millimeters. And so this has implications when injections are made, that is cerebral bar block when you make, you have to know how much volume you have to give. And the intraocular pressure is normally 12 to 20 millimeters of mercury. And the ophthalmic surgery can be intraocular or extraocular. Squint surgery is, of course, it's a completely extraocular procedure. So there is no fear of any protrusion of the eyeball content by increasing the intraocular pressure. And the specific problems for strabismus are increased risk of malignant hyperthermia, high incidence of postoperative nausea and vomiting, and the oculocardiac reflex intraoperatively. So these are the common things that we have to remember. And for adults, strabismus can be done under completely local anesthesia block itself, whereas the children will not cooperate. So you have to keep them under. So it's a trigeminovagal reflex. The oculocardiac reflex is a trigeminovagal reflex, which can lead to arrhythmias, including sinus bradycardia, junctional rhythm, atrial ectopic or AV block, bigeminy, or wandering pacemaker. So many things can happen in ventricular rhythm, but the commonest is sinus bradycardia. And the triggers for this is the traction on the extraocular muscle or the pressure on the orbital structures or ocular trauma, and increase in intraocular pressure from injection of hematoma. And the response generally disappears as the stimulation is discontinued. This is called vagal escape or OCR fatigue. So repeated stimulations may cause the vagus to become fatigued and it will disappear slowly. So if it becomes very severe and the heart rate goes to less than 40 and doesn't improve, then stop stimulation, give atropine 0.1 milligram or 10 microgram per kg IV. Increase the depth of anesthesia, make sure there is no hypercardia, and ask the surgeon to be gentle in further manipulation. So this is the pathway of the picture. It is through the long ciliary and short ciliary nerves. This is the afferent pathway. It comes to the Basarian ganglia, then goes to the trigeminal nucleus in the brainstem, then comes to motor nucleus of vagus, and the efferent pathway comes through the vagus nerve. So that is the pathway. And the oculoemetic reflex pulses from extraocular muscles go to the vestibular nuclei and will glandular formation, then close proximity to vomiting center and nausea and vomiting. So this picture will tell you about the stimulus rising from the extraocular muscle going to the medial longitudinal fasciculus reticular formation, then going to all these structures and then causing this particular problem. And oculo-respiratory reflex is a shallow breathing, which is sometimes go to fully respiratory arrest also. So again, this is another trigeminal-vagal reflex, and but this is only if you allow the patient to breathe spontaneously. If you control the ventilation, this does not become of any importance. And the induction technique, method of airway control are all the preference of the anesthetist. Maintenance usually achieved with the volatile agent. You can use TIVA if you have a family history of malignant hypothermia. And the prevention of post-op nausea and vomiting is very, very important. So you can use all the combination of dexamethasone and ondansetron works out very well in these cases. And the intraoperative opioids are better avoided as they can aggravate the nausea and vomiting. So the supraglottic airway that is preferred is the flexometallic type of LMA. Okay, that's called LMA flexible. Or the other preferred technique is cupped oral ray tube. It is called, and what is force duction test? Is the test done by the surgeon intraoperatively to distinguish the paralyzed muscle from the normal muscle. So they will ask you for full paralysis. So the paralyzed muscle or the fibrous muscle will be still taut, whereas the normal muscle will totally relax. And so by pulling that muscle, you will be able to identify whether it is a paralyzed muscle or a normal muscle. That test is called the forced duction. Duction means pulling. So forced duction test. And how can the anesthetist help? You can use neuromuscular blocking drugs to produce complete muscle relaxation. This will paralyze and relax the muscles with increased tone, but cannot relax the muscle restricted by mechanical causes. So Bellstein is another problem that can happen intraoperatively, where the eyeball will go up for the eyelid. So that is the, so you have to pull the eyeball down and try to do the surgery. So to avoid this problem by adequate depth of anesthesia. So it usually happens under inadequate depth of anesthesia, and you can achieve the depth by inhalation agents or giving a propofol infusion. And this is how the surgery is done. You can see they resect a small portion of the muscle and then try to bring it and suture it. So the eyeball moved, the muscle is brought forward, so it can be adjusted accordingly. Yes. So this is the end of that. Right.
Okay. Any questions from students?
think everybody is clear.
Sir, what normal syndromic issues can arise with strabismus, sir? Can this question be asked, sir? Any syndromic features have to be rolled out?
Yeah, preoperative history is very important. It can be associated with the muscle. Usually, it is associated with some muscular dystrophies or family history of malignant hyperthermia. So that history is very important. But majority of them have isolated strabismus with no other congenital anomalies. That's why I said you have to look for CVS, CNS abnormalities before taking up these children. So isolated strabismus is not a major problem, except that it's a pediatric anesthesia. Separation anxiety will be there. Otherwise, same as any other pediatric.
Yes. Any more questions from students? Please.
So now that we have given them a trial of how to take history and examine a live patient, I think this experience is more than enough. These last two classes, so we will just go on to back to the original method of giving case scenarios, so that we can avoid the trouble of asking them to locate a live patient and taking history and all that. So we'll go back to that. We have some 2 or 3 major. We have not discussed lung. We have not discussed liver. We have not discussed scoliosis. So whatever topics left out, we will sort it out and give those case scenarios for you next week, so that you can prepare and come on. Okay.
Yes, sir. Okay, sir. Thank you, sir.
Thank you.
Can we sign off today's question, sir?
Yeah.
Thank you, sir.
Yeah. Thank you, sir.
Thank you.
Thank you.
Thank you, sir.
Thank you, sir.